Welcome to Beyond Sound. Whether you're a clinician, researcher, or healthcare professional, Beyond Sound is your backstage pass to the evolving world of hearing restoration. This podcast is brought to you by the Hearing Group, which is written with a double R, by the way. And to kick things off, we'd like to introduce you to the Hearing Group. And right after, we'll jump straight into today's topic, which is minimal outcome measurements in pediatric CI users. So, what is the Hearing Group? If you've never heard of it, it's an independent global network of centers of excellence in hearing restoration. We explore the full spectrum of auditory care and especially the full spectrum of hearing loss. We are actively present across 5 continents, united by a shared mission to collaborate, share knowledge, foster innovation, and improve patient outcomes worldwide. Now, what can you expect content-wise? Each episode brings you the latest clinical insights, research breakthroughs, and expert conversations on cochlear implants and cutting-edge hearing solutions. In addition to the audio, we always provide you with a video so you can easily follow the slides. But if you're tuning in while driving, well, maybe just stick to the audio because your airbags will definitely thank you. Our main speaker today is renowned hearing expert, Dr. Anouk Hofkens, and she'll be delving into minimal outcome measurements in pediatric CI users. Her talk will be followed by a discussion around the topic featuring esteemed names such as Professor Javier Gavilan, Professor Rudolf Hagen, Dr. Lisa Park, and Professor Mohan Kameswaran. And now, make yourself comfortable, plug in, press play, and join us as we go beyond sound together.
And we are in Belgium to introduce Dr. Anouk Hofkens from Antwerp. Anouk is a highly experienced audiology specialist and director of the University Rehabilitation Center for Communication Disorders in Antwerp. We are really honored to have you, Anouk, among our panelists today. The whole web is yours.
Thank you, Professor Gavian, for the introduction. Good afternoon, everyone. The hearing outcomes in children with hearing impairment are based on both objective and subjective measures. However, there's no real agreement in the methods that are used by clinical professionals in the field. And so there's a growing need for international quality standards on minimal outcome measures. The implementation of such a standard test battery would allow us to pool outcome data from the same measures across different centers, and this can provide us with very valuable data. On the other hand, a standard test battery allows us to monitor a child's progress and development, and this can facilitate the optimization of the intervention program, including counseling, the speech processor programming, and the rehabilitation. So together with the members of the hearing group, we wanted to set up a minimal outcome measures test battery for children with cochlear implants. And this resulted in a consensus paper that was published earlier this year. So in the next following minutes, I will go through the test battery with you. It was divided into different age categories since the age of the child determines which measure we can use. And also different test intervals were provided. Both objective and subjective measures were included in the battery. The objective measures are equal for all children. Preoperatively, those tests were performed to identify type and degree of hearing loss. During surgery, the ECAPs are recommended to verify the auditory nerve function. And also electrical impedance telemetry should not only be performed during surgery, but at every other test interval, since it provides important information on the efficiency of the electrical stimulation through the electrodes. Then the next outcome is aided, unaided tone audiometry. Here, the test battery recommends to use in these children insert earphones when possible. And since the audiometry requires cooperation of the child, it's important that we adjust our test method to the developmental age of the child. So behavioral observation audiometry, visual reinforcement audiometry, and conditioned play audiometry are techniques that we often use in these young children. But even when these children get older and we use conventional audiometry, it's also important to adjust our test instructions to the child's age. Speech audiometry is an indispensable component of the test battery. It provides us with information on speech understanding at suprathreshold levels. It can be performed in quiet in children from the age of 2 years old, but often they have limited vocabulary, and so the test battery recommends to test in these young children with closed set lists, and then when they grow older, you can use open set lists. Also recommended to test in the best aided condition first. So this is the best representation for the daily listening condition. Speech in noise should be performed when possible with adaptive procedures. As mentioned before, also subjective assessment is included in the test battery. So indirect measures as the categories of auditory performance, speech intelligibility rating scale are used in all children at all test intervals, and they provide us with information on the auditory perception, on speech intelligibility, but in a more real life situation. Also, Little Ears questionnaire is recommended as a subjective assessment tool. Then we want also to assess language development. And here at least expressive and receptive language should be assessed. But in these young children, often there are no standardized tests. So often checklist observation and questionnaires are used. We found the communicative developmental inventories a very useful and reliable tool to assess language and communication skills in these young children. And then when they grow older, we can use standardized language tests. There is also considerable evidence that children with hearing impairment are more vulnerable for mental and motor developmental delays. So it's important to also take these domains into the test battery and to assess mental and motor development with age-appropriate assessment tools, pre-operatively, and then, if necessary, yearly thereafter. So in conclusion, the use of a minimal outcome test battery in children with cochlear implantation would allow us to perform international multi-center studies with a large cohort of patients. And on the other side, it allows us to monitor and standardize our clinical practice. Thank you.
Thank you very much, Anouk. And now let's have a discussion about this. I think that this is a very important topic. And in fact, the hearing group has been working on minimal outcome measurements for many years. So do we need, I will ask Professor Hagen, Rudolf, do we need a minimal outcome measurement, a minimal outcome test battery for young children, or this will be the same as other minimal outcome measurements?
Of course, we have to do a specialized minimal outcome measure in young children because this is completely different to adults. But as you already mentioned, this is really important to get information from all the centers so that we can really make some statements which are important to accompany the progress, because we have a continuous progress in the field of cochlear implantation, also in the field of indications. And this is the basis. If we have enough results from different centers, from different countries with this minimal outcome results, then we really have scientific background.
Excellent. I totally agree with you. But the problem is, how can we assess which are the valid measures to check a very young children? Lisa, can you tell us what you consider to be the most important valid measures for very young children?
When they're very, very young, it's difficult to track their progress, and that's something we need to do before they're able to participate in closed or open set testing to make sure they're on the right track. What we have available to us right now are questionnaires, so the Little Ears, the ITMAs, the Functional Listening Index, those sorts of things, where we interview parents or we observe them in clinic to make sure that they are meeting developmental milestones and are making progress in terms of their auditory development. So I think those are really important tools that we need to use in those early years before kids are able to participate in closed and open set speech perception testing.
Okay, great. And if we just focus on the audiological tests, Anouk, which are the tests that you apply, let's say, during the first 6 months after a cochlear implant surgery?
Yeah, we always, yes, first we try to do the audiometry in free field with the cochlear implants. And yeah, often it asks several test sessions just to be able to have information on the full frequency range. And we repeat it just because it gives us also information for the further fitting. When children are old enough, we also use from the age of 11, 12 months the age discrimination test, and this is a discrimination task which will give us very important information on the ability of the child to discriminate between two phonemes. And it will be important because it says something of the frequency resolution power of the child. So if the results are not good, or if there is some pairs that are not phonemes that the child's not able to discriminate, then we can make adaptations in the fitting software. So, but unfortunately, the other test, speech audiometry, is not possible in these young ages at this time. So we have to, next to these measures, audiometry and age discrimination, we have to base on results of the subjective assessment tools, yeah.
And there are great differences in the development of these small children. You see, we do surgery in children with syndromes. So of course, there is a great variety in the development of a child. If you do the surgery within the first year of life, you include all these children with the syndromes and children who have a normal health status. So this is a little difficult to include all these into one group, in my opinion.
Of course. Well, Mohan, I don't know if you want to say something, or we'll leave surgical details for later on, but if you want to say something, just please go ahead and tell us your opinion.
I mean, I think basically I've just agreed with whatever Anouk's been saying. It's a very challenging area in very young children, and even more challenging, I think, in the developing world, from where we come from. And in countries like India, where there are so many different languages, it's an even greater challenge. But I do agree. I think the standards have to be very stringent. We have to develop uniform standards. It's very important.
Okay, young people working on that are really concerned about fitting. And I will ask, let's start with Lisa. I will ask you, do you apply objective measures when fitting? And if you do, which are the ones that you use?
We do whenever we can. ESRT can be a very powerful tool, but can be very difficult to get on very young children because they need to sit still and be very quiet during that testing. So we will use that, but we rely most heavily on behavioral measures for those really young children. So it's really important that they learn very early on how to perform those tasks so we can get the most valid information possible from them to be able to make the best programs possible.
Anouk, she said we do whenever we can, when we can and when we cannot.
Yeah, for us it's the same. We start with during surgery, it's the ECAPs, but it's just to verify the auditory nerve function. And then we try to do behavioral fittings. And only if we're not able to obtain any reliable responses during the behavioral fitting, then we try the ESRTs. But as Lisa already said, the child has to sit still, and there may be not fluid in the ears, and so there are some limitations in this test. Yeah, so most of the time we rely on the behavioral tests, absolutely. But
Good.
I'm curious because I've seen that there is also already been some research on cortical evoked auditory potentials in adults that was used for optimizing the fitting and for behavioral thresholds. So I'm interested, maybe this can give some more information, but still we have no clinical experience with that.
Lisa, you have anything about cortical information, cortical potentials?
I don't, but man, that would be lovely if we could have some more objective measures that could help us program these very young children.
Mm-hmm.
And the others? Yes, Mohan, go ahead.
Yes, I think our audiologist, Ranjit, he has quite a lot of experience with cortical potentials. He relies heavily on it in these difficult children. And I mean, I can't speak for him, but I know that he finds it very useful, when doing, because it's not just a test of, cortical hearing. It's also a test of cortical maturation, which is very important because it's, I think, the only really available tool we have now for assessing cortical maturation over a period of time. So that way, it's a very useful tool. I think it will probably, in my opinion, become very important as time goes on and we have more experience with it.
Professor Hagen, do you have any experience on cortical measurement?
Yes, we have a research program and also already started in children, but this will last, I think, maybe 1 or 2 years until we have the first results. But I think we should also mention one important factor are the parents. The feedback from the parents in the children, because during test situations, maybe the child is tired and so on. And the continuous feedback from the parents also is a very important part for the fitting and for the feedback, how CI is really, is it effective or not?
Yeah, and I'm sorry. Yeah, that was a good comment, but not only from the parents, but we also rely a lot on the feedback of all the other specialists, all the other therapists that are involved in the child. That's also important. Yeah.
Good. So let's stay with the parents. And what is the most important thing to stress to families of children who receive implants at an early stage? Lisa.
They have to wear them all waking hours. We've found that even more important than the date and then their age at surgery is the age that they start wearing their device full time, which makes sense because you can put the device in, but if they're not getting access to sound, they're not going to make progress. So that full-time use is the most important thing, and it can be so difficult for these very, very young children to start wearing those devices full-time. We tell parents it's going to be a full-time job. We make sure that that's a really important part of counseling in the beginning, give them strategies to get devices worn and used full-time.
Anouk, something else.
Yeah, we always start with first reassuring the parents that there will be a whole team available for them that will guide them through the cochlear implantation and all the follow-up. And then also we explain them, we counsel them that normal hearing children hear all day. So that's why it's so important that the child has to wear the device all day. We try to educate them on the importance of early intervention, and we give them strategies how to interact with their children. We explain them why it's so important that the number of their interactions with their children will have enormous impact on the speech and language development of the child. we also think that it's very important that we guide them in the maintenance of the material so that they know how to use the device, that they know how to check. So we ask the parents, so before they put the device on the head of the child, just check if everything's working. But it's important that parents feel confident, and if they do, they will absolutely be part of all the intervention program. Yeah.
Okay, thank you very much. I think we can spend the whole day dealing with this topic, but we have 3 more topics, and so we have to move to the next one, and we will keep our turn around the world. So now we are going to move from Belgium to the United States, to North Carolina.
And that wraps up today's episode of Beyond Sound. A big thank you goes to Dr. Anouk Hofkens for sharing her expertise on minimal outcome measurements in pediatric CI users, and also to our esteemed panel, Professor Javier Gavilan, Professor Rudolf Hagen, Dr. Lisa Park, and Professor Mohan Kameswaran. If you enjoyed this episode, don't forget to subscribe, leave a comment below, and share Beyond Sound with your colleagues and peers. The more ears we have here, the better. So, you can find more resources and slides and bonus content on our website, www.hearing.com. And in case you feel like connecting with the Hearing Group community on our social media, we welcome you to follow us on LinkedIn, Instagram, YouTube, and Facebook under @HearingGroup with the double R. There, we share everything from the world of hearing implants from under the lens of the Hearing Group. So again, thanks for listening, and until next time, stay curious, stay connected, and as always, let's go beyond sound together.